Yes, sir. 32-year-old female, 32-year-old male medical representative presented with right hypochondrial pain since 1 month duration. He has prominent vessels on the abdominal wall.
Okay. Can you just tell what you make out of that? Thanks.
Sir.
Can you make out what is it? Tell some differential diagnosis.
He has a long-standing right hypochondriac pain, so it can be a case of liver abscess, and there might be CLD, chronic hepatitis.
Yes. Anything else you are talking about? Anything else come to your mind?
Right hypochondriac pain might as well be lower lung pathologies can also present like that.
Any other possibility? Okay. So you have given us 4 possibilities now. We'll go one by one.
Yes, sir.
The first possibility you said is liver abscess.
Yes, sir.
So what are the usual presentations of liver abscess?
Patient has a history of presentations with fever, history of long-standing right hypochondriac pain in this case. It might have progressed to CLD. That
is there history of fever here?
No history of fever.
So there's some point against liver abscess. And liver abscess will manifest earlier. Why to go for 1 month? That also looks odd, no?
Yes, sir.
Second possibility you said was cirrhosis liver, no?
Yes.
Can cirrhosis liver produce pain? Does it present as pain?
No.
Yes, what do you say? Cirrhosis liver.
Cirrhosis liver usually does not present with pain. Only if there is any inflammation, acute hepatitis in the setting of a cirrhosis liver, there might be perihepatitis and pain might occur.
No, so tell me situations where cirrhosis liver becomes painful.
HCC, development of hepatocellular carcinoma.
That is agreed. What else?
Portal vein thrombosis.
Okay. Any other possibility comes to your mind?
An acute hepatitis with perihepatitis and inflammation.
Why you are bringing perihepatitis here? What do you mean by acute hepatitis?
A viral hepatitis of less than 2 weeks duration.
Viral hepatitis of less than 2 weeks duration. Viral A, B or C, you mean? Okay. Then third possibility you said was chronic hepatitis. Do you think it's possible here?
Chronic hepatitis is possible here.
What should be the duration of illness to say chronic hepatitis?
More than 3 months.
More than 6 months. So that is also not possible. Fourth possibility you said was lung disease. What lung disease you are talking about?
A lower lobe pneumonia.
Pneumonia. 1 month duration pneumonia. Is lungs a painful structure or painless structure?
Painless structure with pleural inflammation when it affects the pleura.
Pleura, okay. So the possibilities you mentioned are 4 and there are odd points for that, so we don't consider them very seriously here. And then the last sentence.
Prominent vessels in the abdominal wall.
What do you make out of that?
This might be due to portal hypertension.
Portal hypertension, one possibility. So causes of prominent veins abdominal wall, one is portal hypertension. 2.
Any obstruction.
Intestinal obstruction or what?
IVC obstruction can cause dilated veins.
IVC obstruction can dilate the veins. Any other obstruction? Can you have veins in the superior venacava obstruction?
Portal vein thrombosis can also cause
portal vein thrombosis.
EXP.
Portal hypertension, no?
Yes, sir.
Yes. So why do you get how do you know it is portal hypertension, superior venacava obstruction or inferior venacava obstruction?
The flow direction of flow. If it is to headward, it is IVC obstruction.
How do you,
If it is below,
how do you detect it? Direction of flow.
we obliterate by 2 fingers. We obliterate the dilated veins and then release one finger, release the index finger, and see whether there is a flow towards that side. If there is no flow, we obliterate. We remove the other finger and see whether there is a flow. So by that we can identify whether the flow is head downwards or from toe upwards.
How do you select the segment of vein? Can you select any segment of vein, or is there any selection method? When you
Any
check for,
prominently dilated segment is selected.
it's an exclusion criteria. Particular segment cannot be taken. Why?
I don't know, sir.
Because if there are tributaries filling the vein, that segment,
Yes, sir.
even if you obliterate, it will fill. So the segment of
Okay,
vein
sir.
should be without any.
Tributaries.
This particular patient, flow was upwards. What does it mean to you?
It means there is an IVC obstruction.
So can you tell me what are the tributaries of IVC? How is inferior vena cava formed? It is formed by joining of two veins from the lower limb, namely
The iliac vessels, the common iliac veins.
Common iliac veins. And inferior vena cava ends at what level?
Um,
It joins the right atria. It
Yes,
drains
sir.
blood to right atria directly. So what are the tributaries it receives on the way?
Azygous vein.
Azygous vein 1, okay. This is easy to remember for students. There's a mnemonic. Portal system return to liver in humans. Portal system returns to humans to liver in humans. Portal T.
Yes, sir.
Phrenic vein. System S. Suprarenal vein. Return R. Renal veins. T. Testicular vein. L. Lumbar veins. I. Iliac veins. And very important, last but most important is humans. H. Which vein is that? Hepatic vein. So you have got tributaries like this. So now once you say this is a IVC obstruction, you know the tributaries. Tell me why there are prominent veins on the abdominal wall. The flow is upwards. Which are those vessels you are seeing on the abdominal wall? What is the communication between when there is a block in the inferior vena cava? Blood is drained to superior vena cava through anastomotic channels seen on the abdominal wall. What are those vessels?
As
Lateral thoracic veins. There are communication between superior vena cava and inferior vena cava. There are 4 communications. Azygous hemiesophageal vein you already mentioned. There is thoracoepigastric vein, lateral thoracic vein, internal external mammary veins. There are communication between the two. That's why you're seeing prominent veins. So how do you differentiate from portal hypertension veins from inferior vena cava obstruction? What direction of flow in portal hypertension?
above downwards.
Normally what?
Away from the umbilicus. In portal hypertension should be away from the umbilicus, and inferior vena cava also should be from below downwards. I mean below upwards.
So what is normal direction of flow? In a normal human being, what direction of flow?
From above downwards. From
Normally flow is away from umbilicus, and portal hypertension, that is exaggerated. So this particular patient has got inferior vena cava occlusion. You know these are the tributaries V, S, R, T, L, H and I and H. So how do you localize where is the block in this particular patient? inferior vena cava has to be seen as upper segment, middle and lower part. Upper means above the liver, above the drainage of hepatic veins. So how do you localize upper part, middle part or lower part? If it is a obstruction above the level of the liver, you get palpable liver. So palpable liver indicates that is above the level of the hepatic veins. That is why this congested liver has produced pain here.
Yes, sir.
If it is in the middle part, it commonly affects the part below the liver. Liver will not be palpable. And below the lower part, you find it affects the bifurcation and produces lower limb edema.
Yes,
Middle part may affect the renal veins. So above the renal veins, with the renal veins, below the renal veins, the three parts of the inferior vena cava. Above the liver is upper part of block. Below the renal vein is the lower part. In between is the middle part. Okay.
Yes.
So what are the usual causes of? What is your provisional diagnosis here?
This could one possibility is an IVC obstruction itself.
Is IVC obstruction a diagnosis complete or incomplete diagnosis?
Incomplete diagnosis.
What is incomplete about it?
Due to the etiology, that is, it might be a
Etiology,
portal
that's right. Etiology, yes, we told.
portal
So what
vein
all
thrombus.
things you want? What all things you want to get the etiology? History you have to ask, no, to find out the etiology. Yes. The commonest cause of IVC obstruction is usually malignancy, and usually it produces obstruction at the level of the middle part of the IVC. So liver may not be palpable in those cases. And what are the malignancies which can present the inferior vena cava? Compression. What are they? Renal cell carcinoma, pancreatic carcinoma, ovarian carcinoma, rarely large uterine masses. Very important thing is lymphoma producing obstruction. Still rarely in very old people, abdominal aortic aneurysm. Congenital malformations of the inferior vena cava can also produce problems. Extension of DVT in a chronically immobilized patient, obese patient in pregnancy who has sedentary life can have extension of DVT proximally towards the inferior vena cava. We have a group of thrombophilias which can present as IVC obstruction. Can you name few? Protein C.
Protein C and deficiency.
Antithrombin 3, factor 5, Aden mutation. So you can have a couple of even polycythemia, rubra vera. You can have obstruction of a large vessel. So in this background in mind, what all things you ask?
We ask for
fever, anorexia, constipation, any lumps noted anywhere in the body, previous history of thrombus anywhere. How do you recognize hereditary thrombophilias?
Family history will be there, and since childhood, patient might have recurrent bleeding manifestations.
Is it bleeding or thrombus?
Thrombus.
Where do you get thrombus in hereditary diseases? Recurrent is okay. Where atypical sites? Atypical sites. Okay, pulmonary is one.
Pulmonary embolism, DVT, recurrent DVT.
Brain is one. Hepatic vein is another one. Mesentery is another one. So atypical sites you get. Classical venous thrombosis in the lower limb, dependent posture. Can vasculitis produce involvement of vein?
Yes, sir.
Which vasculitis?
medium vessel APLA can produce venous involvement.
APLA can produce venous thrombosis. Does it produce obstruction of very large vein?
Yes.
Can produce. Any other vasculitis you can. APLA is not a vasculitis, am I right?
Yes, sir. Not a vasculitis.
Any other?
Medium vessel vasculitis can have venous involvement as well.
Which one? You know, thromboangitis obliterans.
Yes.
Many times present this is venous occlusion, even before they come with arterial. Another condition that is commonly seen with venous occlusion, venous vasculitis, is called as Behcet syndrome.
Yes,
so what history will ask in this patient?
To rule out Behcet syndrome, we can ask for history of recurrent oral ulcers, recurrent genital ulcers.
Which other organs will be affected in Behcet's?
In Behcet's, the cardiac, there may be cardiovascular involvement. Patient can have valvular lesions can occur secondary to aortic root dilatation, can produce cardiac murmurs.
Not really.
Then hematological involvement, coagulopathy can occur.
Any other involvement?
Renal involvement will be there.
So, right hypochondrial pain, distended veins, portal hypertension, Behcet syndrome, and here come to IVC obstruction. We have mentioned all the possibilities here. What else you want to know now? You already mentioned additional history. What history you get in DVT?
History of long-standing immobilization, recent surgery which requires bed rest, long air travels. All this can predispose to DVT.
What about cardiac failure?
Cardiac failure.
What about malignancy? Perioperative state. Peripartum.
Yes, sir.
Orthopedic surgery. Pelvic surgery. Traction. What about paraplegia and hemiplegia? Paralyzed patients who do not move. So, history has to go extensively. So, this patient had 2 years back DVT, 1 year back uveitis, and oral and genital ulcers recurrently. What do you make out of that?
Behcet syndrome.
How do you explain the second one, uveitis?
In Behcet syndrome, there will be uveitis is a predominant feature and seen in Behcet syndrome, which is typically bilateral, and it is usually pan-uveitis, and there will be recurrent episodic uveitis.
What do you mean pan?
All compartments is involved, entire uveal tract, rather than anterior and posterior, entire uveal tract is involved.
What is the triad of findings in case of anterior uveitis?
Pain.
Pain, one. Redness. Diminished vision.
Yes, sir.
Can you tell them differential diagnosis for pain, redness, and diminished vision?
Glaucoma.
Glaucoma is
Acute angle closure glaucoma.
Very good, that's fine. So, coming back to the aphthe. What do you mean by recurrent aphthe? You said no, oral aphthe. Recurrent aphthe stomatitis, that's what it's called. 2 types, there are minor and major. What is minor, what is major?
Minor aphthous ulcer are less than 1 centimeter in diameter, and the major one.
They are 8 to 10 millimeters only. 8. Okay.
Less than 1 centimeter.
More than 1 is called major.
Major.
What are the causes of aphthe?
Vitamin deficiencies.
Which vitamin?
Vitamin B, riboflavin.
Anything, even iron. Okay. Hematinic deficiencies. 1. Other causes. Very good. Other causes. Some people have got genetic tendency to have family of people with aphthous ulcers. Trauma sometimes can produce from tooth. Those who chew tobacco can have it. What are the drugs disposing for aphthous ulcers? NSAIDs like pyroxicam, Triple can produce. Now, what about the toothpaste? Does toothpaste involved in this business? Some toothpaste containing some peculiar substances are found to have close association. Some people attribute to stress situations, examination, stress. What are the infections in relation to ulcers?
Candidiasis.
No.
Um,
Streptococcus is involved, H. pylori is involved, herpes simplex is
HSC,
involved. Okay, so can you tell me some abdominal diseases producing abscess ulcers? Very important for us.
IBD can cause abscess ulcer.
Celiac disease produces abscess ulcer. That is only clue for you. And Crohn's disease and ulcerative colitis can also produce same pattern. Okay. Tell me something about tumor necrosis factor alpha related causes of abscess ulcers.
And familial Mediterranean fever can have.
Tell me some systemic causes for abscess ulcers. Systemic causes.
Vasculitis, SLE.
Which vasculitis? Be specific. Which vasculitis you're talking about? Behçet syndrome.
Behçet syndrome.
Yes. So vasculitis usually affects arteries, arterioles, capillaries. Few of them only affect the veins. So one is Behçet syndrome. TA I have already mentioned. Yes. Any other? What is magic syndrome? Magic syndrome is a variant of Behçet syndrome where there is mitochondrial inflammation also. A cartilage inflammation is seen with major aspect. Cartilage inflammation major aspect is called as magic syndrome. Okay. Now tell me what periodic fever with abscess ulcers.
Familial Mediterranean fever.
PFA-PA, what is that? PF indicating periodic fever, A indicating aphtha, B indicating pharyngitis, A denoting cervical adenopathy. So that's a periodic syndrome characterized by recurrent abscess ulcers. Particularly if they come with cervical adenopathy, always think this can be the pattern. What is cyclical neutropenia? Cyclic neutropenia. Cyclic neutropenia is a situation where periodically, every month or every 3 weeks, 4 weeks, you find patient goes into neutropenia. And they may come at that time with a fever and other manifestations. So, what other history you want in this patient?
This is possibly Behçet syndrome. So we'll ask for
other system involvement. What are
other system involvement, like a renal disease or articular manifestations, any cutaneous manifestations?
No, renal manifestations are not there. Articular manifestations, arthralgia, arthritis only, nothing much.
Cutaneous lesions.
What are the cutaneous lesions you get in these patients?
Acneiform lesions can be there.
Acneiform lesions can be there.
Erythema nodosum is seen.
Erythema nodosum can be seen. Can you tell me something about erythema nodosum? Erythema nodosum. Tell me something about that.
It is a painful nodular lesions.
Where do you look for it? Where do you look for it?
Which is seen along the shin of the tibia.
Any other area where you get it? For undergraduates, shin is okay. For you, I think more than that. Areas of erythema nodosum.
In the palms.
Oh dear. Is seen in the dorsal aspect of your forearm, commonly. Dorsal aspect of your forearm. It can be rarely seen in the thigh, but these are two common sites. How do they look like?
They are tender nodules. They are reddish nodules.
What happens to them? Natural history. What happens to them?
They resolve spontaneously within weeks.
Does it leave behind any scar?
No.
Do they ulcerate?
No, does not ulcer. They resolve spontaneously.
That is the classical erythema nodosum you are talking about. But erythema nodosum in Behçet syndrome can ulcerate, and commonly it leaves behind a scar.
Okay, sir.
So, what other cause of erythema nodosum? Tuberculosis very common. Leprosy very common.
Leprosy.
Streptococcal infection very common. SLE very common. Inflammatory bowel disease very common. Sarcoidosis is not unusual. People who are taking sulfonamides. So we have varieties of causes for erythema nodosum. You cannot say I do not know. You know. Yes. Other manifestations other than skin.
Ocular manifestation like uveitis. Then severe hypopyon can be there.
Hypopyon can be there. Yes.
Then retinal vasculitis and occlusion is
How
seen.
does this anterior uveitis heal? How does it heal? What do you look for in the eye? Previous history of uveitis, what do you look for in the eye? There will be posterior synecdoche, and you can see irregular pupil because of adhesions. And the retina, there can be retinitis. They can become blind. Yes. Other systems. What do you want to?
Neurological manifestation is seen, but though it is rare.
Which are the neurological manifestations?
Parenchymal, mainly parenchymal disease or myelitis, spinal cord lesions like myelitis can occur. Then pseudotumor cerebri is postulated.
It can affect the meninges, producing meningitis. It can produce dural sinus venous thrombosis, producing just like DVT. You can have. Sequelae, you can have pseudotumor cerebri, and then you can have involvement of your parenchyma. Parenchyma usually around the thalamus. Particular areas are there. Neuro-Behçet, very important topic because prognosis will be bad in those patients, and it will produce patchy involvement. So the differential diagnosis will be from
MS.
Multiple sclerosis. What are the gastrointestinal manifestations of Behçet's? You will ask his history, past history. What all things you will ask?
Weight loss, diarrhea.
What type of diarrhea? So for thrombosis, you have asked all those things. And then we are going through it. Yes, what diarrhea you are asking for? They can mimic chronic ulcerative colitis. Ulcers are the cecum in the ileum and the colon. Lungs, what are you specifically looking for? Lungs, you get pulmonary embolism, pulmonary hemorrhage, and pulmonary artery aneurysms. So, okay. General examination, what all things you want in this patient?
Oral ulcers, cutaneous lesions, as said before, genital ulcers.
Yes. Then what do you want? Irregular people, erythema nodosum, and healed genital scars. Commonly, genital ulcers don't heal by scar, but here you get papery thin scar. So examination genitalia may show evidence of a scar on the scrotum, and that may be diagnostic clue. Patient would have forgot the history, or patient may be hiding it, thinking that it may be some STD-like illness. So he may be hiding. So you have to always examine genitalia, scrotum of males and vulva of the female that you examine. System examination. What maneuver you do for elicitation of veins? Any particular maneuver you can do to elicit the venous thrombosis? You may get venous insufficiency in the lower limb. You can have pigmentation, thickening, duration, venous ulcers. Coming to hepatomegaly, what characteristic you will think about it?
Associated with pain.
It is a tender congested liver. And when you palpate liver, what are you looking for?
We look for the consistency, borders, whether it is tender.
When you have a patient who has got IVC block above the level of the liver, you know hepatic veins are automatically blocked. So you will not get hepatojugular reflux. Okay. So your diagnosis comes as
Behçet's disease with
IVC obstruction.
IVC obstruction. Portal vein.
Suprahepatic, not portal vein.
Suprahepatic.
And etiology being
Behçet's disease
of vein, that is Behçet's disease. So for the investigation, you plan for DVT.
We'll take a venous Doppler.
That's fine. Then what else will you do? Venous Doppler can be done. Yes. Then yes. What investigation will you plan for Behçet syndrome?
For diagnosis,
what is pathology test? What's pathology test?
Pathology test, a sterile needle is pricked into the skin, and we observe for any induration over the site.
After how many minutes?
No, after 2 days.
48 hours.
40.
So you need not go for a injection or a needle or anything like that. Most of our patients would have gone to a laboratory for blood test, and where they drained the blood, when a section was done, that prick itself produced a papule or a pustule.
Yes.
The first case of Behçet syndrome I saw was a patient who was referred saying that this patient is having reaction to all injections. All injection sites, small papules were coming up. So that's a pathology test. Any investigation for Behçet? Any other investigation to prognosticate?
Diagnosis mainly clinical by these criteria.
There are different criteria. This patient got uveitis, he has got oral ulcer, aphthous ulcer, everything. So he is a classical case. What is HLA-B51?
HLA-B51 can be done to prognosis.
But how does it help you? Once you do the HLA-B51, you can almost say positively this patient will develop eye complication, blindness, or he may escape from that. So that's a bad prognostic sign. That's why it is done sometimes. So any other investigation you want in this case?
Liver function.
We have to do a CT scan for this abdomen to localize the IVC obstruction and see the extent of it, and if necessary you may even go to MR, okay, to see the site of the block, because we want to treat the patient. If it is a idiopathic cause, we have to specifically treat. Okay, so what's the treatment for Behçet syndrome? If somebody comes to you with oral ulcers, how do you treat?
If it is just oral ulcers, you can give triamcinolone ointment.
What's triamcinolone?
Topical corticosteroid.
Did it get absorbed?
It is a topical corticosteroid.
It did get absorbed.
Minimal systemic effects.
Minimal, okay. Effect is there. So any other drug you know of?
Colchicine is used for recurrent oral ulcers and genital ulcers.
Colchicine is a good drug. Any other drug?
Then apremilast is used.
What is apremilast?
It is a phosphodiesterase 4 inhibitor. For recurrent oral ulcers, it is given.
Where else you are using this type of drugs? Phosphodiesterase 4 inhibitors.
In pulmonary artery hypertension.
Do you use in the management of COPD?
Yes, sir. Pulmonary artery hypertension.
COPD, what do you use? Starting the letter R, O, F, L,
ROM if it's
Okay. Suppose this patient has got arthritis, what will you do?
Colchicine is given. Prednisolone can be given. If it is refractory,
this is a lifelong disease, so steroid use should be minimum, otherwise they will be steroid dependent.
Okay, sir.
So azothioprine is okay, colchicine is good enough. Anterior uveitis, what will you do?
For anterior uveitis, topical corticosteroids itself is given as eye drops.
Posterior uveitis, how do you do?
Posterior uveitis might require immunosuppression.
You have to start with the
hydrosteroids and immunosuppression.
Then you have to give them some immunosuppression. Which are the drugs commonly given for immunosuppression?
Azathioprine, cyclosporin is given.
Okay.
Then, interferon alpha.
That's right. Cyclophosphamide, methotrexate, even rituximab. Okay. So, how do you prognosticate these patients? What's Wells criteria?
Wells criteria is for diagnosis of pulmonary embolism.
Just tell me about that.
It is the first one is physical findings which are suggestive of DVTs being present,
namely?
like unilateral lower limb swelling, calf or thigh muscle tenderness, which attributes to 3 points.
Will it be cold or warm?
It will be warm.
Warm, okay, right.
Second point is there is no other alternative diagnosis which fits best with the situation. Third one is tachycardia. Then a history of above 100. Then a history of immobilization for around more than 3 days, or a recent surgery in the last 1 month. Then a past history of DVT being present, a past history of pulmonary embolism being present. Then a history of hemoptysis. Then underlying malignancy being present. So you add up all the points, and if it is more than 6, there is a high probability of pulmonary embolism.
Very good. Okay, how do you treat DVT?
Thrombolysis.
Commonly DVT you give anticoagulants. You start with heparin and put them on oral anticoagulants. How long you treat a case of DVT?
If it is not precipitated, if it is an unprovoked DVT first episode, then for 6 months.
3 months good enough. Maximum 6 months, okay. And if it's provoked one,
lifelong anticoagulation will be required.
Okay, just like cancer patient, you have to give for long term. What's the prognosis like?
If there is for DVT, if there is a provoked, if there is a sufficient underlying reason, then
we are talking about prognosis of Behçet syndrome.
It has actually waxing and waning course, like it can recur. There are multiple episodes of remissions and exacerbations.
Is it only a nuisance or is there a serious problem? Can you prognosticate it by any means? When the neurology is affected, CNS involvement, 1, 2, eye involvement, 3, major arterial occlusion, like aneurysm formation, rupture, 4, major vessel occlusion, pulmonary embolism, chronic ulcerative colitis like involvement of the gastrointestinal system, even to the extent of producing multiple sclerosis like picture or CVA like picture, arterial occlusion producing CVA. These are 6 bad prognostic markers, and so it is not always a joke. If it's only oral after ulcer, it is fine. So commonly, mucosal involvement alone, skin involvement alone, prognosis is good. HLA-B 51, bad prognosis by and large. Okay, large vessel neuroBehçet's, very bad prognosis. So, what is HLA-B 51? the specific mark or
ankylosing spondylit.
oh dear, ankylosing spondylitis is actually B27. This is specifically for eye involvement of Behcet syndrome. How is this thrombosis produced in the Behcet syndrome? It possibly is. So it's inflammation of the endothelium. It produces inflammation of the inside of the vessel, producing occlusion. So tell me about Werkow's triad. What is Werkow's triad?
Stasis, increase in viscosity,
and endothelial damage.
endothelial injury.
So it obeys the rule of Werkow's triad. That's how it's producing. So what is life-threatening complications, Behcet's? Pulmonary embolism. Pulmonary embolism. And it is well known to produce arterial aneurysms. It can rupture. What's the peculiarity of uveitis of Behcet syndrome?
Panuveitis.
Name another disease where you get panuveitis. I'm talking about medical problems, no, not ophthalmic problems. Our medical problems which can have panuveitis. Sarcoidosis is another one. And what are the findings you expect in the fundus? Fundus you get classical retinitis. That's what you are seeing. Classical fundus of. So this particular patient, we have seen the tip of the iceberg, namely a tender liver and dilated veins. From that, we have pursued and found out it is inferior venacava occlusion. And from inferior venacava occlusion, we have gone out to find out what are the possible levels of occlusion. And we found out it is the suprahepatic occlusion. Subsequently, we went ahead to find out what the etiology of this occlusion and find out it is a case of Behcet syndrome. From Behcet syndrome, we have gone to find out complications, and we got uveitis also, and we have gone to treatment. So this patient has got simple straightforward Behcet's, but the presentation was for eye reach obstruction. Why it happened like that is because this patient had recurrent abscess ulcer. Symptomatic treatment got well and they just ignored it. They had scrotal ulcers. Again, it's a simple thing, they ignored it. Just like all of us ignore small company. We didn't give an ophthalmologist for your red eye. That was also treated, but there was no correlation. So this case particularly teaches us that past history is very important. When you take detailed past history, you get a proper diagnosis. Otherwise, you'll be stuck with a case of tender liver and eye reach obstruction without knowing what exactly is the cause. As you can see, no investigation can help you to make the diagnosis here. And it's not investigation-based diagnosis, or only clinical diagnosis. So proper history taking, proper examination leads to a very dangerous diagnosis here.